Dr. Swati Naik and welcome for MQR AICUG TV live from Bhubaneswar with rightdoctor.com. I am pleased to have with me Dr. Vidya Bhatt. She is a director at Radhakrishna Multi-Speciality Hospital and IVF Center at Bangalore. She is also an endoscopist surgeon and IVF specialist. Thank you very much for joining us on MQR AICUG TV, ma'am.
Thank you so much.
Yeah. It's pleased to see you after exactly 1 year. We interviewed
exactly.
you on the same topic last year. I think we'll have newer techniques being discussed on this endoscopy in women's health, which is our day-to-day practice now. So, would you like to tell us about what are the current practices for endoscopy in obstetrics and gynecology?
See, there was one era when we spoke about only open surgeries. Now this is the era of minimally invasive surgery. Almost all the surgeries in gynecology can be done by endoscopy, except a few cancers of ovarian cancer and then advanced endometrium and cervical cancers. We can do everything by endoscopy. Of course, robotics is there, which is more precise, but endoscopy is no less, because in our country we have the best endoscopic surgeons available because of our, I think, the techniques we use, and we are used to managing things in low resource settings. So I think ours is the only country where even the well-off person and a poor patient can afford endoscopic surgeries. Now with the advancement of all the equipments and the techniques, we are able to do endoscopic surgeries very well, bloodless. There was one stage when endoscopic surgeries, if the patient started bleeding, they would convert to open. But that days are gone, or those days are gone, because we can tackle it endoscopically with our newer energy sources, then the special dissection techniques and suturing. Suturing is another level 4 of endoscopic surgeries, where we can just take a stitch fast, and our endoscopic surgeons are so good that it is as quick as the open surgeries. So we are able to give this same amount of care or the same amount of surgical technique, precise surgical technique endoscopically as we used to give in open
surgery. Absolutely. So we can say that in today in 2018 we are very well equipped with the different techniques, different tools that are being available for the skilled laparoscopic surgery. Ma'am, how do you prepare a patient for an endoscopic surgery or a laparoscopic surgery? Not only on the patient profile but financially, are there any constraint that the patient comes to you with?
See, we do have different categories of patients coming. I know it is expensive, our the equipments, everything is expensive, but still we can give our patients the best endoscopic experience and surgical outcome to these people. One is, of course, by using the newer gadgets, but if you don't have the gadgets, because everybody can't, a low resource setting cannot have the gadget, or an endoscopic surgeon who's been running to places, one hospital will have all the newer gadgets, but the other low resource setting may not have the gadgets. But here we are able to give the same amount of good surgical technique with the proper dissection and also the suturing techniques. Now when I say proper dissection, initially there was a time when we used to use bipolar cautery when the other equipments were not there, and we used to perform the hysterectomy, which would take a longer time. But now with the good surgical techniques and then lateral pelvic wall dissections, we go and ligate the uterine artery at its origin. Now this uterine artery at its origin can be either done with bipolar, or one can take a stitch or just coagulate and cut. Of course, the newer gadgets like the smart electrodes can be used here, but if that is not available, we can do this. And in a large fibroid, when we ligate the uterine artery, the main blood source, the bleeding automatically comes down, and then we can go ahead and do the surgery. And one more hitch which has come now is the morcellation. And for those things, a morcellator, because of its controversy, people are trying to do vaginal morcellation, and if at all there is a doubt, then we can always open. So these are the newer things or the controversial things which have taken a proper path now, so that there is no confusion for the doctors to do it in a proper channel. So these are some new things. And then of course preparation of the patient. We always tell them the advantage of endoscopic surgeries, and then prepare a pre-operative workup. See, whenever we do endoscopic surgeries, it is general anesthesia. So in general anesthesia, there are certain amount of risk, and suppose the patient is above 50 years or some previous cardiac event, then we have to do a proper workup for the patient, that is an ECG, echo, everything has to be done. And it is always ideal, because these are elective cases, we are not doing it as an emergency, to keep the patient's hemoglobin at least 10 or 11, so that we don't land up with disasters and blood transfusions later. And then finally, after the proper workup, the technique of the surgeon and the setup. One thing is, it is not one person doing, it is the proper OT setup with the proper assistance and the staff. I mean, everybody is a unit here. The anesthetist, the assistant who holds the camera. It's a teamwork. So a proper team has to be there. And then the surgical technique. If the person is not very well surgically equipped, in the sense that technically if the person is not, or the surgeon is not up to the mark, it is always easy to call another person and then do the surgeries, because the safety of the patient becomes the priority.
I think in terms of patient preparation, it goes hand in hand like the way we prepare the patient for open surgery. So right from this blood profile and having an hemoglobin at least 10. So what is there any role of iron, or to be very precise, a parenteral iron that is to be used before and after the laparoscopic surgery?
Now, preparation of the patient, as I said, is very important. Suppose the patient's hemoglobin is less. Now, this is not an emergency, but we can always prepare the patient, and to give the oral iron and prepare the patient takes a long time. So we prefer giving parenteral iron.
We'll have to wait for 6 weeks for an oral iron
Oral
to
iron,
give the
yeah,
rise in hemoglobin.
hemoglobin. So this is within weeks we can improve.
Right.
So we give parenteral iron and bring the hemoglobin up to 10 or 11. Suppose there is a loss, we have a proper hemoglobin to the patient, and due to some problem the patient loses blood. It's a huge fibroid, and then any amount of care cannot control the bleeding, though we take stitches. Some amount of blood is already lost, and then post-operatively we find that the patient has less hemoglobin. In such cases, I think if it is below 8, we may think of blood transfusions, but if it is 8 and above, we give parenteral iron. Sometimes even up to, if it's a well-built patient, even if the hemoglobin falls to 7 also, we have given parenteral iron and improved the patient. And then of course, once it reaches 9, 9.8, then given them oral iron therapy, and we have sent the patient home.
Ma'am, with the availability of various parenteral iron preparations, what has been your experience and which one you recommend or use very often?
I always prefer using iron sucrose for pregnant ladies, and of course
Ferricarboxymaltose.
the ferricarboxymaltose for
That's the latest iron preparation, which is the most stable iron
it's one of my
complex,
favorite product, because I have been giving it to patients, and even not only my pre-op and post-op patients. Suppose the pregnant lady post-operatively has, post-delivery and postpartum period, she has less hemoglobin. For her also we have given this.
Absolutely. So this is the latest entrant in the parenteral iron preparations, which is the most stable iron complex, can be given in a very high dose, single dose, and the with least chances of adverse drug reaction.
Yes.
So I think post-operatively, when you have to monitor the patient 24 to 48 hours, and over and above, if you have some parenteral iron going to give you an allergic reaction and a risk, so your night is all the more fire.
Correct.
So I think you can definitely rely on a preparation like ferricarboxymaltose, which has really been a very good new advancement.
Probably I would call it a boon only to our mothers and women. It's a
any key message that you would like to give to the fellow obstetricians and gynecologists who have assembled here all across the country on this topic? Like, is there a message how to do in a best possible way the endoscopy for your patient with a minimal risk?
See, first thing is proper workup. Any endoscopic case, we should have a proper workup. There is no shortcut.
Right.
You know, we should have an ultrasound, we should do a proper workup, a pre-anesthetic checkup. Everything is mandatory. Second important thing is the setup. If the setup is not good, or if the surgical skill level is not good, always call somebody. Okay, always call for help. There is no ego problems at all. Patient safety should be the priority. So call for help. And once you have a very good setup and a well prepared patient, then endoscopic surgery is very easy, in the sense it is a joy to perform that, and the outcome is excellent to the patient. As all of us know, it is scarless. I mean, it's small scars and patient can get up and walk around cosmetically acceptable. And post operative period, the recovery period also is very less, so the patient can get back to work, and the amount of antibiotics, everything comes down. So I feel first thing is we should all do endoscopic surgeries and learn the proper techniques. Though the learning curve is more, I feel everybody should take up a proper path and learn endoscopic
Thank you so
surgery.
much, ma'am. Just a last question. I'm wanting to ask more and more, but a last question for a budding young gynecologist. Are there any good centers in India where you are talking about the skill and the training, which would come only from the best institute? So, do you recommend any training institute for endoscopy in India or outside
I
India?
think I'll be very selfish if I say it is my center only.
Okay, great, yeah.
But there are very good centers across India. I have been trained in India only.
Okay.
Because I have never gone abroad for an endoscopic training. The best endoscopic training is available in our country.
our country.
I think the advanced surgeons, we have top surgeons like Dr. Hafiz, Dr. Sanjay Patel and all. They give excellent training. And
Sir, at your, ma'am, at your center also you could tell them like what
Yes.
is the number of students that you
I
take in a year.
at a time I take the ICOG fellows for 6 months. Then I have Rajiv Gandhi fellowship for 1.5 years. Then the 3 months training also I have.
So how do the students approach you? If
They
you
can
could just
just
tell
to
them
my
on this video.
website. They can approach. They have my number. They have to just get into my website, Radhakrishna Hospital, or even Vidya Bhatt, or they can just send a mail, vidyabhatt68@gmail.com, and then they can.
Thank you so much, ma'am. I think young gynecologists and obstetricians are definitely looking forward for those admissions at your center. Thank you
you.
so much. Thanks
Thanks
for
a lot.
joining us on MQRAICOG TV.